with iliotibial band syndrome, very often it's part of what you call trochanteric syndrome. So you quite often see the classic triad of glute medius tendinopathy, sometimes trochanteric bursitis, and then the iliotibial band syndrome itself, which is the irritation of the Kaplan's fat pad as the tendon goes in and attaches to the lateral part of the tibial tubercle. The iliotibial band comes down and it splits into two parts. The part that attaches into the upper part of the tibia acts like a ligament, and the other part attaches acts onto the femoral condyle, acts like a tendon attachment. And if you've got strength deficits higher up, and when you're landing your knees rolling into valgus, then it's putting extra tension through the iliotibial band. The iliotibial band is supposed to be taut. I mean, people obsessively roll away on it trying to loosen it up, which, by the way, doesn't work if you roll on the fascial bit. You have to do it up here on the muscular part. But also, it's meant to be taut. If we didn't have the iliotibial band it's got this constitution of Kevlar, by the way. It's almost bulletproof. If you didn't have it, every time you hit the ground, your femur would literally buckle and snap. So it's like a kind of spring. So it's meant to be taut. It's just that if you have faulty biomechanics, it becomes overly taut. And so then you start getting these problems where it attaches into the lateral part of the knee.
There's probably one useful lesson already there, isn't there? Because as you say, people with rollers or whatever are very fond of working on the bit of the ITB which maybe hurts a bit more than the rest. I don't know. But of course, we've had several people on the show, specific fascia experts, saying, well, you can't stretch this stuff.
No, when I worked at the Olympics with a whole group of physios, we were talking about how in gyms you always see people rolling away on the lower part, and actually, if you're going to have any influence on the fascia, you've got to loosen up the muscles that attach into it. So glute medius, glute maximus, lateral part of the quadricep, and even the hamstrings. But you're not going to achieve anything by rolling away on the band itself.
Should we talk about symptomatology and things like that for ITB syndrome or runners generally? I mean, normally it's a sort of insidious pain. It starts off as a sort of dull aching pain. It very often happens whilst you're running, particularly towards the end of a run. And it's often if you've changed your distance, we've been doing hills, you've done something different, and you haven't really prepared yourself. So you start getting a sort of dull aching pain. It gets progressively worse, and it starts earlier and earlier each time you're having a run. And then you start to notice it in activities of daily living. You start noticing it going up and down stairs, and it's a horrible sort of burning pain. My patients love it because I've had most of the symptoms. I've actually been having exactly that on this right knee. So it's a very unpleasant burning pain. And the differentiation of it is to make sure you haven't got any sort of lateral meniscus or lateral collateral ligament pain. The differential diagnosis of it is done through clinical testing. You can image it, obviously. You can, if it's not resolving, then you would do MRIs and so forth, and you can pick it up then. But in terms of orthopedic interventions for it, it's controversial whether you inject the Kaplan's fat pad with hydrocortisone, because what you don't want is to shrink it. Because if you shrink it, then you're damaging its whole function. So the sports doctors I do a lot of work with are very reluctant to do that, unless, of course, you were an Olympic runner and you had a 1,500 meter race and it was a life or death. So you'd inject it in certain circumstances.